Is it working?
Yes, ma'am. Yeah, we can see it.
One second, let me see now since we are there. Okay. The video is playing. What time we plan to start?
Yeah, in a minute, madam. We were just waiting for actually you to just test your screen share. I'll stop it now. We can see them.
Okay, you have stopped it. Okay.
Yeah. Madam, if you do have the Zoom background, could you just change it? We are just starting in 1 minute. I'll request
What
others
you want me
to.
Did you send it to me?
We did, madam, on your email as well as on your WhatsApp. If you can check on your email, which was sent by me, it'll be there. If it's not, that's also fine, madam. Anyway,
can you resend it to me?
I'll do that, madam.
That background actually. Okay, the image. So email it to me.
I'll do that, madam. I just starting the live telecast, and we'll begin with the program. In meanwhile, I'll just send it, madam. Good evening, everyone. Welcome to today's masterclass brought to you by the Academic Council of IASO. Today is the 53rd chapter in our series. This is the third year that we have been doing it. And to deliver the welcome address today, we had Dr. Subrameshwar Rao, our convener, but unfortunately, he's just held up in a case, and I'll be doing the honors on his behalf. I welcome everyone, seniors as well as colleagues, as well as residents to this webinar today. The topic is going to be non-epithelial ovarian tumors. For people who are logging in for the first time, this is something that we do once every 2 weeks, which was started in the year 2020. This is our third season into it. And from Basutarkam, we would like to thank the IASO President, Dr. Das, and our Secretary, Dr. Chandramohan, and all our advisors from North, South, East, and West, namely Dr. Arnab Gupta, Dr. Sanjeev Mishra, Dr. Sadasivam, and Dr. Rajgovind Sharma to help us run this program on a clockwork every 2 weeks. We welcome our examiners for today. We have Professor Amita Maheshwari, who is the head of the Division of Gynecologic Oncology at the Tata Memorial Hospital, Mumbai, and she's also the president of the Association of Gynecologic Oncologists of India, which is AGOI. We thank you, ma'am, for giving us your time and putting a lot of effort into putting the content of today and the case capsules and expert talk. Welcome, ma'am. We have Dr. Kavita Sukumar, who will be the moderator for the mock exam today. She's an associate professor of surgical oncology at the Madras Medical College, Chennai. And she's also the course director of the postdoctoral fellowship program in gynec oncology. She also has a post of consultant at the Kaveri Hospital, Chennai. We thank Dr. Kavita for putting a lot of effort into preparing the cases for today, which I'm sure all of us will see and learn from. The examinees for today are going to be Dr. Ganesh Babu, who is a resident from Tirunelveli Medical College and Hospital, and Dr. Manindra Naik, who's from AIIMS Patna. Both the students are residents in Department of Surgical Oncology. A few instructions for the session to the examinees. When the examiners are asking questions, please be to the point. And if you don't know something, just tell it so that the moderator can move ahead and save us some time. Keep catching the hints that these examiners have a habit of giving. To our moderator, Dr. Kavita, we request you to address the examinee by their name to avoid confusion. So Dr. Manindra and Dr. Ganesh, you can ask them who's supposed to be answering the question so that there's no confusion. And we also request you to ensure that both of them are getting equal opportunity to participate. To both our examiners, in interest of online viewers, we have viewers here on Zoom. We have some viewers who are logging in on YouTube directly, and there'll be many more viewers who will be viewing this on YouTube later. So if there are some answers which have been incorrectly answered or which remain unanswered, we request you to kindly give the correct answer in interest of the other participants. For the senior ISO members, we thank you for logging in, and we appreciate that the comments which you post in the chat box. The residents who are not participating but are live, it's a unique opportunity because you can ask all the questions to the examiners themselves, and we will make the examiners answer in the last part of our Q&A session. I'll be keeping the time, and I'll be reminding at 30 minutes, 45 minutes, and 60 minutes via chat to our moderator. The first session will have 60 minutes. With that, I request Dr. Kavita to kindly load up her screen and take the first session of mock exam forward. Thank you.
Thank you, Dr. Shukla, for the kind introduction. Good evening to one and all. At the outset, I'd like to thank Professor Subbu sir for this wonderful opportunity, and also IASO for giving me this opportunity to be a moderator in the session, and also to the opportunity to share the platform with Dr. Amita Madam, who's my teacher and who has always been my inspiration all through. I was there with her in 2008, I think, and she never fails to inspire me. Thank you so much for that. And I will share my screen right now. Yeah, is my screen visible?
Yes, ma'am.
Yes, ma'am.
Yeah, I'll put it on. Fine. So we'll move on to the case discussion. And the first case for today is an 18-year-old girl who had come to us with lower abdominal fullness and pain for 2 weeks duration. And she had no other complaint. Her menstrual cycles were regular. On examination, her performance status was 1. She's good performance status. She had a firm, non-tender mass occupying the right iliac fossa and suprapubic region with restricted mobility. She did not have any deposits on peritoneal examination. Okay, so I will ask Dr. Ganesh. So when you see such a patient, how are you going to, what are the things that come into your mind, and how are you going to, yeah.
She's a patient of an adolescent age group.
Yeah.
She's of a she is actually hemodynamically stable.
Yeah. Okay.
And she used a short duration of abdominal fullness. First thing is I will do.
Yeah, I think is the audio good?
It's breaking, madam.
Yeah. Okay. Yeah. Please,
Dr. Ganesh, would you like to have any other information? Are you? Are you using headphones? I mean, we can't hear you.
Yes, ma'am. But someone's audio is on. That is the problem.
Dr. Maninder, would you like to take it?
Yes, ma'am. Ma'am, I would like to take the complete history and followed by clinical.
Specific you want to know?
Ma'am, age of menarche.
Okay.
So duration and onset of pain, and the onset
No,
of
the pain is only for 2 weeks. She was normal 2 weeks back, and she's got pain and lower abdominal fullness just for 2 weeks duration.
Like to know if she is sexually active about her last menstrual period.
Yes, ma'am.
Yeah. So why it's important?
Ma'am,
I think Dr. Ganesh, you need to fix your audio. Meanwhile, Dr. Naik, you can continue. Yeah. Why it's important to know these things? Your slides are moving.
Yeah. I'll just.
Sir, ma'am, in germ cell tumors, in certain tumors, there is
No,
like
so we don't know
either
it's a germ cell tumor, right? So girl has come, a young, healthy person otherwise, and who has just 2 weeks of pain and fullness. So why you are jumping to the diagnosis of germ cell tumors?
okay.
Not
Ma'am, we need to add history regarding the secondary sexual characters.
okay. She is post-menarche, and of course, that we'll get to know only on examination, but she appears to be a bit, as per her version, there's nothing. Anything in the history and why menstrual history and sexual activity is important?
No, could I mean, if she had missed a period, anything else would come into your mind?
So,
No.
anyone of reproductive age, you always have to keep the possibility of
Miss,
pregnancy. Okay. So it could be intrauterine pregnancy or extrauterine pregnancy. Women of reproductive age, regardless of which forum you are, you have to know about the sexual activity, and pregnancy has to be ruled out. Okay. So this very well could be a ectopic pregnancy. Why are you saying germ cell tumor? We don't know.
Okay.
Right.
Okay.
Anything else you want to know associated with features?
Thyroid status.
Sorry?
Status of the thyroid.
Symptoms. We are talking about symptoms.
Ma'am,
Right.
any rectal
History
symptoms
you want
and
to ask.
bladder symptoms?
Bladder and bowel habits. Yes.
Bowel habits.
Right. Also important to know the history of fever, isn't it?
Yes, ma'am.
Is it important? Okay.
Could it be any infection?
It can be.
So what kind of patient is not sexually active, and what kind of infections you can expect causing a mass, fever, a pelvic mass?
Ma'am, salpingitis.
What is more common in
Abdominal
India?
TB. Abdominal TB.
You can have abdominal tuberculosis. No?
The right-sided pain or left side?
It is the right-sided pain.
So what else? Just don't think because it's a gynec case.
Appendicular
Don't worry
mass.
about tubes and ovaries. Okay, yes. Appendicular mass. Okay. Right.
It can be a
So
mesenteric cyst.
I think we have limited time.
Yeah. So how are you going to evaluate this patient, Dr. Ganesh?
Ma'am, I would like to do an UPT and prove it negative.
Okay.
And I'll go for further blood investigations, ma'am. Routine blood investigations, followed by X-ray of the chest, CECT of the abdomen. Before that, transvaginal ultrasound.
No, she is an 18-year-old girl, and she is unmarried and she's not sexually active. So will you do a transvaginal ultrasound for her?
Routine abdominal ultrasound can be done.
So whenever you have, abdominal mass, first line investigation is an ultrasound, right? So if you want to characterize what you're not even sure, no, you haven't done, you can't even do a PV for her. So first line investigation would be an ultrasound. Okay, so what are the things you pick up on an ultrasound?
I'll know the status of the mass, whether it is cystic or solid, or whether it is mixed, and is there any ascites, and whether the findings are confined to one organ or there are peritoneal deposits. So such details
the
I
thing
can
is
get.
are you sure it is an ovarian mass right now? So the first thing you do on an ultrasound is to find out which organ it arises from, right?
Yes.
So whether it is from the uterus or from the ovary or from outside, the first thing you do is where the origin of the mass, and then you characterize the mass, right?
Yes, ma'am.
Madam, would you like to ask?
No, go ahead.
So ultrasound done shows A predominantly solid mass in the right adnexa. The uterus appears normal, endometrium normal, minimal free fluid. Okay. Predominantly solid with few cystic areas. Okay. And so what next?
Marcus,
Yes. What
AFP,
markers? Yeah, Dr.
AFP,
Maninder, would
HCG.
you, no, Dr.
That's
Maninder.
Before we go to Mark, can you just enumerate causes of pelvic masses in a female patient?
In this age group, madam?
Oh, no, generally in this age group and as well others.
Yeah, Dr. Maninder, you can take that.
Madam, ma'am, question.
So the question is, what are, common masses you will see in lower abdomen?
Ma'am, lower abdomen, ma'am,
women.
in case of female, maybe ovarian mass, maybe mass originated from the appendix, ileal,
Okay,
from ileum,
okay,
any retroperitoneal mass.
okay, very good. What else? You want to add, Dr. Ganesh? Don't forget the
Para ovarian
uterus,
masses.
uterus, broad
Para
ligament,
ovarian masses.
Broad ligament.
ovarian masses, broad ligament fibroid, uterine fibroid. Okay. What about mesenteric cyst,
Mesenteric cyst.
sigmoid masses, right? So we're not talking about now right and left, pelvic masses essentially.
So
Okay.
either you go organ based, you say from the uterus, from the ovary, and then you say benign, infection, benign and malignant masses. So you classify like that, then you will know. You will try to come.
Right. Very correctly, Dr. Kavita mentioned that you should go organ wise and also benign and malignant. Okay.
That's right.
Right. And another cause, this thing can present as pelvic masses, pelvic kidney. Okay. Which is extremely rare, but you have to be just be aware of that. Okay.
Okay, so shall we proceed, madam?
Yeah, you were on ultrasound findings.
Yeah, so tumor markers you were telling, Dr. Maninder? What markers?
Serum AFP, LDH, beta HCG, serum inhibin.
Yeah, okay. So what are these
Serum
markers?
C125.
Yeah, 125. So which markers are for what?
Ma'am, serum AFP is usually raised in yolk sac tumors, and in embryonal carcinoma, both AFP and HCG both are raised.
Yeah.
And in dysgerminoma, there is elevation of serum LDH and PLAP. And
What are the other germ cell tumors that you know of?
granular cell tumors, there is
No, germ cell you finished one. Any other germ cell tumor? Very common.
teratoma. Teratoma,
Yeah,
none
yeah.
of serum markers are raised. In immature teratoma, sometimes rarely AFP, serum AFP is raised.
Yeah. In dysgerminoma, sometimes you can have borderline elevations of
Inhibin.
HCG.
Dysgerminoma, LDH.
You can have borderline elevation of HCG in dysgerminoma because sometimes they'll have syncytial trophoblastic elements within them. So it is possible. A lot of times these markers are negative. Okay. So why do you do inhibin?
The inhibin is usually raised in granular cell tumors. And anti-Mullerian hormone. Both are raised in granular cell tumors.
Okay. So this, see, when do you do, ultrasound is the first line investigation, agreed. So would you like to compound the investigation or after an ultrasound, would you do any other investigation or any other imaging in what conditions would you like to do? Like if a patient comes to you with a complex ovarian mass.
I mean, ultrasound usually on grayscale and both combination grayscale and color Doppler. You used to see both morphological features and the vascularity of the tumor. Morphology, if there is irregularity of wall thickness, irregularity of septa, if there is any solid or papillary like masses, and is there any ascites, peritoneal nodules, or any evidence of metastasis. And in CT, we usually see the greater anatomical delineation is seen in CT scan now. And to be better end status and metastatic status in any free fluid with CT scan. And usually in masses like indeterminate ovarian masses or any indeterminate masses, we usually confirm by MRI. So T1 fat suppressed images and T2
Yeah.
images.
Okay. So just tell me in a nutshell, when will you do an MRI? When will you do a CT? Or will you do both for this patient or any other patient? I'm talking about first line investigation, ultrasound, agreed. So which
Ultrasound,
patient,
yes, ma'am.
yeah, which patients you will do an MRI, which patients you will do a CT following an ultrasound?
If there is indeterminate masses, MRI is usually used to differentiate between benign and malignant tumors.
Yes. So when you have benign also in your differentials, if it is only a complex ovarian mass or characterization of the mass, then MRI is the best modality. So when can you do a CT, contra CT? You could do MRI for that as well, but contra CT?
From CT, we can assess the better lymph nodal status and if there is any evidence of distant mets.
Yeah, so in an advanced case, you would prefer to do it's easy to read for us generally. A contra CT you would prefer if it's an advanced disease. So this is how you go about. So this, what is this? Can you just comment, Dr. Ganesh? Can you just comment on this image?
Yeah, which sequence are we looking at? Are these T1 or T2?
This is T2, madam.
Why you say so? Is it written there?
Why is it a T2 image? T2 weighted.
The solid components are enhanced.
No. To say it is a T2 weighted image, what are you looking at? How do you say it is a T2 image? Not looking at the mass, you look at something else and you say this is a T2 weighted image.
You
right?
said T2 weighted. Why did you say T2?
Based on any other component, when you look at something else and say whether it is a T1 or T2 image.
Okay, how does fluid appear in T2?
Hyperintense.
So what are you looking here? Can you identify the bladder here?
The cursor is with me, madam.
Yes.
So
Sorry?
I think the cursor is with me, only I can do,
Yeah,
I think.
okay.
So that is the,
Yes, madam.
okay.
It is hyperintense.
So that's how you say it is a T2. And so what is the finding?
There is an adnexal mass with both solid and solid components.
So it is a lobulated mass. You can see it's a lobulated mass like this, predominantly anterior to the uterus. You can see the axial section, it is anterior. Okay, so this is part of bladder, right? And so then it has got predominantly solid, few cystic areas, right? So
Yes.
what is this? Can you see my arrow?
Yeah, it's seen, yes.
Yeah.
Yes,
What
Yes,
is?
ma'am.
Yeah, that is the uterus, and
uterus.
the endometrium.
The bladder, plane with the bladder is maintained or no?
It is actually maintained, madam, but
No, I'm asking him.
Okay. Okay.
It's maintained.
Okay. Right.
Okay. So shall we proceed, madam?
Yeah.
I think shall we skip this, madam? We did have.
We have to, what are, solid masses like this? What are the differential diagnosis in this age group? That's narrow.
This is predominantly solid, right? So what are the differentials?
It could be a dysgerminoma.
Yes.
No, don't say like, histological diagnosis. Germ cell tumor, yes.
Yes, ma'am.
Unless you know features of dysgerminoma on radiology. Never be so confident. I don't say dysgerminoma or yolk cell tumor. Okay. Germ cell tumor.
Germ cell tumor.
Which other differential?
Differential from ovary. Yes. Any other differential? Germ cell is one. Any other category can you get? This age group? You were doing other tumor markers and all, right?
Yes, ma'am.
Yeah.
Teratomas.
No, see, teratomas are all germ cell, right?
We just discussed, inhibin. Inhibin is a marker for which ovarian tumor?
Sex cut. So it's got
Granular.
stromal tumors.
Stromal tumors specifically for Dr. Maninder?
Granular cell tumor, ma'am.
Granulosa. Granulosa, how many varieties are there? Granulosa cell tumors? Subtypes?
Ma'am, subtypes I don't know.
There are
Juvenile-
adult and
Juvenile
juvenile.
and adult.
Yeah,
Very good. Juvenile and adult.
okay.
So what else?
So you said germ cells, then stromal tumors, granulosa and other type of stromal tumors, and what else can present this way? Solid mass. Can you have any uterine mass? What are the commonest uterine masses that you can see?
Don't only think in terms of malignancy.
Fibroid.
Yes.
Fibroids. You can have, pedunculated fibroids. This very typical, similar appearance you can have. Okay. So it will present less an adnexal mass because of the pedicle. No, sometimes it will not be picked up on imaging. So it's always a differential for solid ovarian masses, wherever you have broad ligament fibroids, pedunculated fibroids, subserous fibroids. All of these are differentials of adnexal masses. Okay. Then what else? Have you heard of, these adnexal masses coming to you with acute pain? What do you think of?
Torsion
Rupture.
hemorrhage, ma'am.
So you have heard of torsion detorsion syndrome? When sometimes what will happen, these masses, even normal ovary can undergo torsion and detorsion. Okay, so they become enlarged and they present with only ovarian edema, only stromal edema. So large, 10, 50, even 10 or 12 centimeter ovarian masses
Yes.
with just edema, large appearing, normal appearing OP, which is big. Okay, it's called a torsion detorsion syndrome. Quite common in this age group. We keep seeing.
I
them.
just remember this because we have a few cases where bilateral ovaries were removed thinking malignancy and turned out to be massive ovarian edema. So there's a entity called massive ovarian edema.
You
because of
really have to
torsion,
remember
there is
this. You have to suspect that one because it's quite a common mistake that they make. It's a very benign condition. You don't have to remove the ovaries. You just have to detort it and fix it to the side wall and come off, and they settle down. So this is something where you don't have to remove the ovary. So it has to be kept in mind. Okay.
The metastatic tumors can present as solid masses. Okay.
Okay. Shall we move on, madam?
Yes.
So in this case, AFP is 1.3, beta HCG 23, CA 125, 97, LDH 290, and inhibin B is 3. So what are we dealing with? Dr. Ganesh?
This is a teratoma.
Why are you saying it's a teratoma?
I'm sorry, ma'am. This is a dysgerminoma.
Okay. It is,
It's a,
yeah.
the LDH is raised.
LDH is just borderline raise. It's not. See, LDH,
Borderline.
how significant is it?
HCG,
LDH as a diagnostic marker? No, to
Right.
say that LDH is elevated, so this you can have this tumor. Is it a very specific marker?
no, ma'am, it's non-specific. It just shows the tumor potential.
Yeah.
There is a borderline elevation of the HCG.
Yeah. So with the sometimes see most of the times in dysgerminomas, your beta will be normal. You can have CA 125 elevation. See if this you take this as significant CA 125 97. Significant or not?
No, it is again. It is mildly elevated.
It is mildly elevated. Can be because of several reasons, some peritoneal reaction, anything can be there. Okay. So
HCG, can it be elevated in any other cancer or is it specific to, germ cell tumors or
Choriocarcinoma.
gestational choreo? Apart from that, this kind of low level of HCG. Okay, so it can be elevated in many other epithelial, very low levels could be, in say urothelial cancers or many other cancers. So these are not always necessarily associated with gestational or non-gestational choriocarcinoma or dysgerminoma.
yeah, even in
Dr. Kavita said CA 125 is again a very non-specific marker. Okay, as a diagnostic test, it has poor sensitivity. It can be elevated? What are other causes where benign conditions where CA125 can be elevated?
Endometriosis,
Okay,
PID,
right.
You think you were talking about uterine masses, right? What uterine masses can cause CA125 elevation?
What is also very common in our country and can mimic ovarian malignancy? So it
You
can
were
be
talking about some
tuberculosis, abdominal tuberculosis, endometriosis, leiomyoma, pelvic inflammatory disease, even pregnancy. So
pregnancy.
CA125 is a very non-specific marker. Anything which causes peritoneal irritation can give rise to high CA125. Okay, so never make a diagnosis of histological diagnosis, at least in this kind of case, that it is a dysgerminal. Okay, it's probably a germ cell tumor. We don't know. We still don't say it's a dysgerminal. Okay, next, what is that?
So how is a germ cell tumor presentation different from an epithelial ovarian cancer? Can
its
you,
presentation is
Dr. Maninder, you can take this question.
Ma'am, first of all, it's the age group. Mostly epithelial ovarian cancers usually present in older age,
Yeah.
more than 40, and germ cell tumors usually present less than 40, or some 6-cord stromal tumors usually present later. And in germ cell tumors, the presentation is like any pelvic or abdominal mass, any pelvic pain, or
What will be the
sudden
duration of history?
short duration history, ma'am.
Okay.
Any bladder bowel symptoms, any menstrual irregularities.
No, menstrual irregularity for whom?
For germ cell tumors, ma'am.
Okay, but it's not very specific for now. Why do you have why should you have a menstrual irregularity for a germ cell tumor? What are you talking about when you're talking about menstrual?
Germ cell tumor can have menstrual irregularity.
When do you have menstrual irregularities in germ cell tumor?
Ma'am, in granulosa cell tumors.
No, germ
No,
cell,
germ
granulosa
cell.
is
Germ
not a germ cell tumor. Okay. We are not talking about granulosa cell tumor, we are talking about germ cell tumors.
Sometimes you can have these germ cell tumors coming to you with menorrhagia. Okay, so when does it happen? Dr. Ganesh?
Past, we are,
Ma'am, monodermal teratoma. Ma'am.
No, see, whenever there is a beta HC elevation, I guess madam should say. So when you have an
tumors secreting HCG can cause isosexual sexual precocity. Okay. And just going back to my statement, generally you won't make histological diagnosis, but one condition where beta HCG is very, very elevated, we may see it in the lags, then one is reasonably sure that it's a case of choriocarcinoma. Okay, so although pure ovarian choriocarcinomas are rare, but if beta HCG is highly elevated, then one can take the diagnosis of choriocarcinoma.
Okay, so how are you going to manage this patient? Dr. Ganesh?
and we have the imaging details followed by the markers. And when we think it of as a dysgerminoma, and this is confined to the ovary. So, and the patient can be planned up for a fertility preserving surgery, unilateral salping oophorectomy, followed by further treatment based on the histology reports.
So, would you do a laparoscopy or laparotomy? Dr. Maninder?
Ma'am, laparotomy.
Laparotomy. Does laparoscopy has any role at all in this kind of scenario? Anytime when you choose to do a laparoscopy? No or yes?
No.
No. Sometimes, see, in this case, you have these marker elevations and all. So if you don't have a marker elevation, you are not sure of what you're dealing with. It could still be a fibroid. Okay. It could still be a fibroid, which could probably be managed by laparoscopy. No, there are. So it is, and she's a young girl. You want to give her a midline laparotomy for a fibroid. No, little over treatment in those regards. So if you're not sure, very sure of diagnosis, it's a good thing to put in a scope and see what you're dealing with. Okay. So whether it is a fibroid or a ovarian mass, just make sure it is. When you put in a scope, you'll know whether it's coming from the ovary or a uterus. Then you can, based on that, you could do a diagnostic laparoscopy. When your diagnosis is not sure, you could put in a scope, see if it's a fibroid, you manage accordingly. You could do, there are people who can do, myomectomy, in-bag morcellation, remove it, all of that is possible. So you see what is happening inside, then you can, so it has got a role. But if the minute you know it's an ovarian mass, then obviously you're going to do a laparotomy. Okay.
Yes,
So
We need to be little wind up by some 25 minutes remaining. So,
okay. So this was the intraoperative finding, and you can see the lobulated mass from the right ovary. Okay, there was little 100 ml ascites, and there was some, the UV fold was thickened, the mass was adherent to the UV fold, congested, and this left ovary had small, it was also cystic, it was not normal. And there was one small yellowish nodule which we could see within the left ovary. There was no enlarged palpation. Now, how are you going to go about managing this patient? Dr. Ganesh. Now, these are the intraoperative findings. So what are you going to do? What are you going to do to the mass? You said unilateral right side, salpingophlectomy, fine.
Yes,
What else?
yes, ma'am.
What are you going to do to the left?
First, I'll do a peritoneal sampling.
Yeah, okay. From
From
where?
the pelvis.
From which?
When there is a minimal ascites,
Yeah.
it can be collected, or there should be a washing done.
No, this 100 ml ascites is there. We've collected the ascites. Fine. That is okay. Then
you
what?
have selected the ascites, adenexectomy. Now the question is, other ovary also looking a little bulky and some yellowish area. What will you do? Will you address it, or will you leave it, or will you do salpingophrectomy on this side also in this 18-year-old?
Actually, whenever we think it of as a dysgerminoma, the bilaterality, the chances of bilaterality is of around 10 to 20%. So whenever we find the contralateral ovary as abnormal, we can do a biopsy.
So Dr. Maninder, what will you do? Your opinion?
I will do biopsies, sampling from the contralateral ovary.
Yeah.
If there is any cystic mass, we can do cystectomy, only cystectomy, ovarian cystectomy, and 6-quadrant peritoneal biopsy, and biopsy from the omentum and peritoneal vasings.
Okay. Now, supposing this opposite ovary is normal looking, then what will you do?
Nothing, ma'am. Opposite ovary is normal, then we have to do nothing.
Okay. So if it is
Dr.
looking abnormal,
Ganesh, you said 10 to 20% risk of other ovary involvement. What will you do if this ovary was normal looking? Would you take random biopsy? Would you dissect it, look for any abnormality, or will you leave it alone?
Leave it alone.
so and what about nodes? Will you do a lymphadenectomy or?
No, ma'am. Is
It
there
is
any
categorical or will
radiologically,
you-
ma'am, is there any palpable nodes during surgery, or is there any evidence of radiological evidence of nodes? So we can remove on that palpable nodes only. No formal lymphadenectomy required.
Yeah, okay. So yeah, I think when you have opposite ovary involved in germ cell tumor, what are the possibilities? You said dysgerminoma, then anything else, Dr. Maninder? When can you have contralateral ovarian involvement?
Ma'am, we can do ovarian.
No, but what conditions can you have? No, the opposite ovary being involved in a germ cell.
Ma'am, dysgerminoma and
Yeah,
immature teratoma.
Yeah, in immature teratomas also you can have contralateral dermoids. Okay, so this was done, and this final histopathology came out as dysgerminoma from the right ovary and both right and left ovary. The left ovarian this nodule was also dysgerminoma. Ascitic fluid positive for malignancy. Omentum and peritoneum shows inflammation. So, what is the final stage, Dr.
This is
Ganesh?
this is a C3 disease.
Yeah,
Stage 1C3.
Yeah. So how are you going to manage her, Dr. Maninder?
In case of dysgeneminoma, fertility sparing surgery can be done in stage 1A,
we have
1B, and
already
1C.
done.
No, we've done surgery.
Fertility sparing surgery, ma'am.
Yeah, we've done all that. Histopathology has come now 1C3, the diagnosis is. So now how are you going to further management I'm asking about?
So the
Ma'am,
question
active
is, does she
surveillance.
need anything additional now?
Ma'am, active surveillance.
Dr. Ganesh?
Ma'am, sorry,
And
ma'am.
since
Ma'am, if acidic fluid is positive for malignancy, ma'am, if they are, because we have not done the complete surgical staging, we have to go for adjuvant chemotherapy.
Yeah, not because we haven't, no, yeah.
Had we done comprehensive surgical staging, 1C3, we wouldn't have given anything. And especially considering that our other ovary, actually, we have just removed the tumor. We have not done complete salpingo-oophorectomy. We are not sure, right? So this patient, I would definitely give her adjuvant chemotherapy. Regardless if staging was done or not, she is a candidate for adjuvant chemotherapy. Which chemotherapy will you give her?
BEP regimen, bleomycin, etoposide, and cisplatin.
How many cycles?
3 to 4 cycles, ma'am.
3 to 4 cycles.
No, you
In
have will
4
you
cycles
give 3
for
or
one.
4. In a given patient, you can't say 3 to
3 cycles.
When do you give 3 and when do you give 4 cycles?
Ma'am, in this patient, we will give 3 cycles of BEP, and in advanced cases, we'll give 4 cycle BEP.
Okay.
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 Okay. Do you want to take this question? Supposing we are the pathologist is not able to make sure the patient is not able to confirm the diagnosis of the germ cell tumor, then do you have any IHC marker to say?
Yes,
Okay.
ma'am.
Yeah. What are the
SAL4, OCT3/4, and SOX2. In dysgeneminoma, only SAL4 and OCT3/4 positive.
Yeah, okay, we do have. So glypican-3 and AFP for yolk sac. Okay, we have the SAL4, SAL-like for protein 4 is the marker for a germ cell tumor. Okay, so and do you grade these tumors, germ cell tumors? Ganesh, Dr. Ganesh?
We don't usually grade germ cell tumors.
None of the germ cell
Any
tumors
germ
is
cell tumor
In teratoma, it can be graded.
immature teratoma.
Immature teratoma.
Yes, immature teratoma can be graded based on the neural elements.
So how do you
it is always graded, okay? It's not an option for pathologist. Okay, you have to grade. Why you have to grade? What is the importance of grading in germ cell in teratoma?
In teratoma, stage 1, grade 1 can be observed. Grade 2 and grade 3 should be considered for adjuvant chemotherapy.
Right. So grading in teratoma has prognostic as well as therapeutic implications. So one has to always grade a teratoma.
Okay, so this number. What are the toxicity of these regimen?
In BEP, for bleomycin, there is pulmonary toxicity, so it cannot be given for age group more than 40, and there will be decrease in diffuse lung capacity of oxygen, decrease in DLCO in bleomycin, and for etoposide, there is chances of secondary cancers like acute myeloid leukemia, and for cisplatin, there will be ototoxicity, nephrotoxicity, and neurotoxicity.
Do you have a fixed lifetime dose for bleomycin, Dr. Ganesh? More than not do you have a life?
Usually it is 30 milligram per meter square.
You talk
bleomycin
units, right? Bleomycin.
30,000 units, ma'am. International units. Bleomycin.
Yeah,
30 units weekly. 30 international units weekly. So the maximum dose you can give for a person is around 400. Okay. So for children, you try and restrict even up to 2 or 3 cycles, maximum 270. You don't give it very, young girls and all. The recommendation is less than 270. You try to. So afterwards, you can give 2 or 3 BEP, and then if you want one more cycle, you can follow it up with 2 EP. So that also can be done. So you try and restrict it because of some of these pulmonary toxicity, it can be fatal. So very careful about how does it manifest, bleomycin lung toxicity? What happens to the lung Embryo
Pulmonary fibrosis.
pulmonary fibrosis. Okay. Okay.
There
So
is slightly different protocol for pediatric germ cell tumor. There, in adult germ cell tumors, there is higher propensity for chemotherapy. We give chemotherapy in all except stage 1A immature teratoma grade 1 and dysgerminoma stage 1. All other tumors we give, while pediatric groups has, different protocols. Okay, I think we have just 15 minutes remaining.
So we'll just go off to the next case, madam, or
Or maybe
you want to take any of these questions? Just let me know.
What is this gliomatosis peritoneum?
Maybe it is seen in immature teratoma.
Yeah. So what is this gliom? It is seen in immature teratoma. So what is gliomatosis?
The distribution of neural elements, neural tissues in ovarian, that the ovarian tumors spread to peritoneum.
So it's
What kind of
glial tissue, right? Not neuro. It's glial tissue.
Glial tissues.
mature?
Mature, and it is graded as grade 0. So although if it has spread, it will technically become stage 3 disease, but that is considered as benign, and it's most not because of metastasis. The hypothesis is this glial tissue is because of metaplasia of the tissue, not metastasis. That's one of the hypotheses. So you don't upstage the patient and do not give chemotherapy. This is not a chemosensitive situation. So surgery is the only treatment.
So after treatment of an immature teratoma, markers normal, and when you keep the patient on follow-up, you're suddenly developing a peritoneal mass and it is growing.
Growing teratoma syndrome.
Okay.
So
So
I think let's move to the next case.
yeah. Okay. How do you follow up?
For follow-up, we have to see the clinical examination, chest X-ray, abdominal ultrasound, CT, thorax,
No, just tell me
abdomen.
how. No, you can't wait. How
Follow-up, ma'am.
frequently you follow up?
4 to 6 weeks, ma'am.
So you do it's normally for other tumors, you ask them to come three months, every 3 months once. Here it has to be monthly or 2 monthly follow-up.
2 months.
Yes,
So you follow up with the markers and then also imaging. You have to remember that. Okay. So most of the
When you have not given chemotherapy, right? You won't do CT scan every visit. How often will you do CT scan if at all you want to? do
First month, 3 month, and 12 month. First year, CT scan.
you could do it.
More aggressive follow-up is in patients where chemotherapy is not given.
Okay. So in premenarcheal girls, any other investigation you'll do? For
Karyotyping, ma'am.
because of?
Rule out in dysgenetic gonads.
Gonadal dysgenesis.
Yeah, okay. So obviously when it comes out as XY, what will you do?
Total abdominal hysterectomy, ma'am. No need to preserve the uterus. If there is any
Preserve the uterus, but
Uterus?
Both the ovaries has to be removed.
Yeah, you do a bilateral surgery. Why are you doing a oophorectomy? Because of the risk of?
Again, the risk of dysgerminoma.
Gonadoblastoma. No, the gonadoblastoma is the one which occurs, and from them only dysgerminomas can arise. So usually these are associated with gonadoblastomas, from which dysgerminomas. Mrs. Madam has already asked. So I think we'll go off to the second case, madam.
yeah, maybe we'll take it as like just few questions.
So 50-year-old woman presented with postmenopausal bleeding on and off for 1 year, abdominal distension. For 3 months, she attained menopause 3 years back. On examination, showed a lower abdominal mobile mass, and she did not have any pelvic deposits. Her CA-125 was 16, CEA was 1. Ultrasound showed uterus enlarged with multiple fibroids, endometrial thickness 13 millimeter, and she had a 10 cross 10 cross 7 centimeters, again predominantly solid mass in the right adnexa. Now this is the imaging appearance, almost similar to the previous case, and you can see there is some amount of ET 13 millimeter postmenopausal women. You think it's significant, Dr. Ganesh?
Yes, ma'am.
Yeah. So what
I do a Pipel's curettage.
So an endometrial biopsy showed hyperplasia with focal atypia. Now, what are the possibilities in this patient?
Granulosa cell tumor.
Hormone secreting tumor. Okay. So need not be granulosa cell. So one is a hormone secreting tumor. So what are the possibilities when you have an ovarian mass which with a menstrual problem, like in this age group. She's also got an endometrial thickness which is elevated. So one is a hormone secreting tumor. So what are the other possibilities when you have a uterine, pathology associated with ovarian mass? Can it be a C endometrium?
Can be.
It can be.
C endometrium involving ovary? What stage?
Stage 2.
So you can have a, it's not stage 2.
I'm sorry.
Okay, so it is stage 3A. Okay.
Stage 3.
3.
So 3B is vagina and parametrium. Okay. So 3A disease, C endometrium. So what other? Can you have two different tumors, ovary and endometrium? Can
Yes,
you
ma'am,
have?
can be.
Yes, ma'am.
What are the possibilities? I'm asking you differentials of an ovarian mass coming to you with menorrhagia. Advanced C endometrium, hormone secreting tumors. What else?
Anything
Anything else? You can have synchronous tumors in the endometrium and ovary. Some of the ovarian tumors can, again, like previously discussed, no? It can stimulate.
Endometrioid pathologies.
Yeah, endometrioid cancers can be synchronous. So these are all the possibilities. Okay, so we talked about these tumor markers and how will you proceed?
Rarely Krukenberg may present. So, Krukenberg. Why? There is stromal hyperplasia in Krukenberg, which can cause
Bleeding.
hormonal imbalance in bleeding.
So even in Krukenberg's, the patients can come to you with bleeding. You'll have to remember that. Okay. So how will you proceed for this patient? Dr. Maninder?
Ma'am, we will do serum tumor markers. All the markers like AFP, beta HCG, LDH, inhibin, CA125.
Which is 50 years, you will do AFP, beta HCG, everything. Huh? Generally, for all patients, you do AFP, beta HCG. No? Germ cell markers are done generally up. Maximum which age you will generally get a germ cell tumor?
30 to 40.
30.
You can stretch your limit generally 40 years. Yolk sac tumors rarely can come up to 40 years. Generally, in a postmenopausal women, we do not do germ cell markers. It's only epithelial and of course, granulosa cell, you can do inhibin B if you're suspecting a granulosa cell or a hormone secreting tumor. Generally, we don't do germ cell markers in a postmenopausal. So these markers were normal. See, CA125 is normal. We would still think it can be an epithelial tumor. Can it be an epithelial tumor? Ovarian malignancy.
It can be a mucinous or a borderline type of malignancy. So
you saw the imaging finding, right? Very solid appearing. Okay, so can it be a mucinous tumor like that? Very solid, totally.
It can be a borderline tumor. So the CA125 is a normal limit.
You think this age group and this image appearance is of borderline tumor?
Usually, our topic is non-epithelial, but then borderline tumors, we do not have this complete solid appearance on imaging. Usually doesn't happen, right? Usually, if a borderline serous tumor will be cystic with papillary projections, borderline mucinous tumors will have multi-loculated mucinous material or cystic. Okay, so those are typical imaging appearance of borderline tumors. So that
the sensitivity of CA125 for early stage invasive epithelial cancer. Your concern here is CA125 is not elevated. What is the sensitivity of CA125?
For stage 1 epithelial ovarian cancer.
What percentage of patient will be elevated?
70. Maybe.
Stage 1. Early stage.
Around 50%. Okay. So in 50% with early stage, you can have normal CA125.
It's very important you have to remember. We do get early cancers. 20% of them will be stage 1 and you can have normal CA125. So even in high grade serous and you have low grade serous, all of these, you can have normal CA1. So CA125 normal does not rule out epithelial ovarian cancer.
Yes.
To remember that. So this, we are not sure what you have an ovarian mass, which is significant or not. Solid ovarian mass like this, you think it's significant or not?
Yes.
Oncologically?
Yes, ma'am.
Yeah. So what are you going to do for her? Dr. Ganesh?
I'll do a CECT of the abdomen with proceed with surgery.
Yeah, okay. Surgery, what surgery? Just tell me what surgery you do.
Staging laparotomy.
Okay, so you put a midline incision and this is the finding. The uterus has got multiple fibroids and this is a right side ovarian, ovarian lobulated mass like this. So what are you going to do now? You directly proceed with staging or will you do something else?
I'll do a oophorectomy, send a specimen for frozen section.
Yeah, so Dr. Maninder?
Yes, ma'am.
Will you do a frozen or will you proceed with staging?
Ma'am, for postmenopausal age group patients, we will proceed for staging.
Proceed with staging. Huh? So what staging, what is the extent of staging that we will do?
Ma'am,
Dr. Maninder, you can tell.
total abdominal hysterectomy, varitus salpingo-oophorectomy, 6-quadrant peritoneal biopsy, plus omental biopsy and peritoneal washings.
That's all?
And if there are any enlarged nodes, then bilateral pelvic node dissection, either enlarged nodes, should remove that nodes.
So you're not even sure of what the cancer is. So if it turns out to be a high-grade serous cancer, will you just do a sampling? Okay, fine. We will do a pelvic and only pelvic or
paraortic? Paraortic.
Paraortic also.
So you've done important between the two, pelvic or paraortic?
Pardon, ma'am?
Which one is more important between
Ma'am,
pelvic
paraortic.
and
Paraortic.
Yeah. So always say paraortic, it's just not pelvic. Okay.
See, generally speaking, paraortic dissection, does it come with the morbidity or not? What are the morbidities following a paraortic lymph node dissection? What is the problem with that?
Delay in bladder bowel movement, ma'am.
Yeah.
Retrograde ejaculation. Sorry, ma'am. Delay in bladder and bowel movement. That's all.
No, but whenever complications are asked, you have to tell intraoperative and postoperative, right?
Intraoperative, ma'am, bleeding, injury to ureter.
You have big, major vessels there. Can you injure them? Can you have? Okay, you can have vascular injuries, IVC. Okay, even renal vein. The high paraortic is the most important, right? So you can have injuries, you can have ureteric injuries. Then what else can happen? Postoperatively?
Post-op ileus.
Yes, then. Can you have chylous ascites?
Yes, ma'am.
Okay. So can you have diarrhea if you disturb those sympathetic nerves? Is it possible? So you have, it is quite a morbid procedure and you've done that and final histopathology comes benign. Okay, are you justified? It comes out as, say, a fibroma. Okay. So are you justified in doing the entire procedure for a postmenopausal woman, putting her through all the complications just for a benign condition? Is it okay? No, I'm asking you.
So why did you not say that you would send it for frozen? What are your reservations? You don't have this facility, you don't believe in your pathologist, or you just, any mass you want to do complete surgery?
So it's always better that you do a frozen section. So that is the bottom line. So especially if it's available, or you make sure it is available. Now at least nearby centers, it will be there. Right?
So if frozen section is available and if you have not done it and you have done everything, comprehensive surgical staging, and patient develops any complication and she sues you, then you will be in trouble. Okay. So if it's available, you have to do a frozen section examination.
It's always better. So you do have an error component in frozen section, plus or minus 10% can be, you can have an error component, over and under diagnosis, but still by and large 90%, they will be able to tell you whether it's positive or malignancy.
It will be a shared responsibility between pathologist and right?
Okay, so always try and do a frozen section. Of course, doing a hysterectomy is not a problem. I mean, you could have got the consent, she's got postmenopausal women, that is okay. You can proceed with hysterectomy, BSO, even omentectomy. By the time the results come, then you can go ahead and do the other staging procedures, right? So this is a granulosa cell tumor, and so would you give an adjuvant? It's confined to the ovary, 1A stage. Would you give chemotherapy for her? Indications for adjuvant chemo, Dr. Ganesh?
Based on the adverse features, ma'am.
Yeah.
Whenever it is
So when-
more than 10 to 15 centimeter of size, and when it is a poorly differentiated histology,
Okay.
we can plan for a adjuvant chemo.
No, that is one. See, only based on size is relatively older clinical thought. Poor histology is
Adult
fine.
granulosa cell tumor, 20 centimeter, mitotic count is low, maybe is low, will you still give chemotherapy? What you
No,
said,
ma'am.
yes, poorly differentiated or high grade cytological features, there you would give, but just based on size, you will not give chemotherapy, right?
Yes, ma'am.
Which stage will you give onwards? Will you give
One,
chemotherapy?
1C, ma'am.
Yeah, 1C.
1C2 and
Right.
Yeah, in juvenile granulosa cell tumors, even in 1C1, even if you rupture, you will have to give 1C1. No, it's more aggressive than the adult granulosa cell tumor. So even 1C1, you'll have to give chemotherapy. 1C1 onwards, it's fine. And advanced disease, you'll give adjuvant chemo. What chemo you will try and give, Dr. Maninder?
For granulosa cell tumors, ma'am, EP can be given.
Yes,
EP, ma'am.
EP. You could also give any other regimen, Dr. Ganesh?
Paclitaxel and carboplatin is the recommendation from NCCN.
Yeah, you could give both. No? It is the choice of
The juvenile, we prefer giving BEP.
BEP.
In
Younger
adults, you want to avoid bleomycin, so there you can give EP or paclitaxel.
Okay. Can you name some of the stromal tumors which really exhibit malignant behavior? Now, it's a huge spectrum, right? From benign, you have borderline malignant potential and really malignant, potentially malignant lesions. So, can you name some of the histological types? We already
Fibrosarcoma,
even granulosa cell,
small cell carcinomas,
small cell carcinomas.
small cell.
Small cell carcinoma,
Are they
ovarian.
classified under stromal?
Hmm.
They do not come under stromal. They are more of a neuroendocrine variety, right? Okay, so what else? Very, very aggressive stromal tumor.
Sertoli lady cell tumor.
Sertoli lady cell, you have a grading again for a Sertoli lady, like your immature teratoma, you have a grading system. So poorly differentiated Sertoli lady cell, they can be really malignant. Okay, and presence, if it is a Sertoli lady cell, presence of heterologous elements, no, like chondroblast, I mean cartilage, bone, etc. They are also indications for chemo. So whenever you have these heterologous elements, again, you give them chemotherapy. Okay, so then, so can you do, supposing it comes in a younger woman, can you do fertility preservation for this stromal tumors, Dr. Ganesh?
Yes, madam. We can try fertility preservation.
Generally, these tumors are unilateral or bilateral?
Unilateral.
They are generally, yeah, most of them are generally, they are unilateral. As against your epithelial tumors, which are generally bilateral, right? You could offer fertility preservation. But when you do fertility preservation, any precaution, especially if it's you've done a frozen and it comes out as granulosa cell tumor, any other?
Endometrial sampling has to be done.
Yeah, so you have to make sure that they do not have associated endometrial pathology because of hormone secretion.
Yes.
Yeah. Anything else, madam, you want to ask me?
We'll have just 5-7 minutes left, so we'll quickly go
So
to the
we'll
next
move on.
case.
Yeah, next case. This is a 51-year-old woman, premenopausal, and she came to the abdominal pain, vomiting, nausea, loss of appetite, and loss of weight for 1 month duration. Her menstrual cycle is normal. She did not give any history of bleeding, PR, or diarrhea. Performance status 2, she did not have any lymphadenopathy. On examination, she had a firm mass occupying, again, a lobulated mass occupying the lower abdomen, restricted mobility, which was also felt in pervaginal and perrectal examination. There's nothing else, no deposits in the PR examination. Ultrasound showed mild free fluid in the pelvis and bilateral solid adnexal masses, 7 by 8 centimeters, which is also confirmed by CT. Well-defined heterogeneously enhancing solid masses in the adnexa, moderate free fluid with omental nodularity. So this was the finding. And these are our markers: CA125 316, CA 318, CA 99 66.92. So Dr. Ganesh, what do you think you're dealing with?
This is probably this could be an epithelial ovarian carcinoma. The stage could be stage 3, and the CA 125 and the CEA are in the same range, madam, almost. So the pathology could be ovarian pathology.
Dr.
I
Maninder,
do say so that what is CEA? Where do you commonly see elevation CEA? Which condition?
In mucinous
Which organ?
Colon and rectum.
rectum, colon and rectum.
Right.
have you, yeah.
This lady has CA of 318. She has bilateral moderate size masses. You think epithelial ovarian should be your first?
Maybe a metastatic Cooken rectum.
You have to think in what is, have you heard of CA 125 CEA ratio?
25:1.
What is it? What is the
If
ratio?
it is more than 25%,
25.
actually, if it is less, yes,
Yeah.
ma'am.
Ma'am, if the
Less
ratio
or
is
more
more,
than 25.
What does it indicate? If it's more than 25?
ma'am, the C125 series is more than 25 is to ma'am. The origin, the organ of origin may be ovarian malignant.
Yeah. If so, with less than 25, you have to think of extra ovarian origin.
Extra ovarian.
CA 1 CA ratio in this patient. It's almost 1. Right? It's the same value. So less than 25, right? So you must think in terms of extra ovarian. No, it's a metastatic. You have to think in terms of a metastatic disease in this patient, right? So what else will you do? So you are thinking in terms of probably, some where else metastatic ovary, from where all can you get?
Upper GI and
From female genital tract,
Yeah.
stomach, breast,
Yeah. Then
and colon and rectum.
colon, rectum, then
gallbladder,
gallbladder, pancreas.
pancreas.
Okay, you can get it from anywhere. All of these organs, any abdominal thing can go, breast can go. So all of these are possibilities. So any other investigation you'll do for her?
Colonoscopy.
You must do a
Full length colonoscopy.
only colonoscopy?
Both upper GI scopy and
She had vomiting, nausea. No, first line you have to. So Krukenberg's tumors, where are they? Which is the most common site of primary? Maninder?
stomach.
Stomach. You also nowadays, colon cancers are also increasing, almost equal. It has become so. So stomach and colon are the primary, most important primaries. So you must do a upper GI and full length colonoscopy. So when else will you do a GI evaluation? When you have an ovarian mass. Okay. So when will you ask the patient to do a GI evaluation? This is one of the things. When you have the CA 125 CEA ratio with less than 25. Okay. So you're thinking, or CEA elevation. So that is one thing. When else will you do a GI evaluation?
There is bowel symptoms like obstruction, melena, history of melena.
Any GI symptoms?
Bleeding
Yes.
PR. Yes, ma'am.
Yes, then.
Any symptoms like vomiting, abdominal distension.
Yeah, GI symptoms, you will do, see this ratio you will do. Then if you have, see, when all the advanced malignancies will ultimately come with omental nodularity, ascites, everything. So when you have very, very small looking ovaries, not much masses in the ovary and ascites, omental nodularity, there again, you'll have to think in terms of primary. It could still be rarely high-grade serous cancers from the ovary as well. But then you must rule out other from a thing. Would you do a PET CT for her?
Yes, ma'am.
Yes, Dr. Ganesh, yes.
Only as a response to chemotherapy, we do for assessment.
So if you want to do a PET CT for a response assessment.
Yes, ma'am.
So then you will need a baseline PET, right? Without that, how can you assess response?
Ma'am, in this case, if the upper GI and colonoscopy both are normal, and we have to go for PET CT.
Yeah, PET is it is okay. It is you can do a PET CT for this patient, but a lot of times the primary is not picked up. Usually, even in a PET CT. Okay. So in this patient, upper GI scopy showed antral gastritis. Colonoscopy showed ulceration nodularity in 3 areas: transverse colon, ascending colon, ileocecal valve. Biopsy was taken, but the biopsy turned out to be inconclusive. Okay, she has also got omental nodularity. So how will you proceed next?
Omental biopsy, can do omental biopsy.
We can do a omental. How do you do an omental biopsy?
Image guided.
You do an image guided omental biopsy, and it is reported as mucinous carcinoma, suggested IHC for primary. So what IHC markers will you do, Dr. Maninder, to differentiate between primary ovary and primary, GIT? Yes, Dr. Ganesh, you can take that. What marker specific, which are
IHC markers pathologists do in colonic cancer? Okay, let's talk about
Cytokeratin,
which cytokeratin?
cytokeratin 7 and 20.
not five,
7 and 20, man.
7 and
Cytokeratin.
20. Yeah. Which is for GI?
7.
7 is for ovary and 20 is for
For GI.
Okay. Then what are the markers?
Ma'am, PAN-CK, cytokeratin, and epithelial membrane and EMA.
For colon, your markers would be CK20 positive, SATB2 positive. Then you have your CDX2, CEA
CDX2.
markers
Yeah,
for colon.
right?
Okay.
And
So
for ovarian, what are the markers for epithelial ovarian?
Cytokeratin 7.
yeah.
Okay,
Then-
one is CK7 and you must have seen
Any
like
malaria
pathology report was
It's a common Mullerian marker. You can do Paxate. Okay, it can be positive. It's a Mullerian marker. Then
and don't you get report saying WT1 positive?
it is an indicator for WT1 is an indicator for what?
Mesothelioma.
No, for serous cancers. WT1 is a marker for serous cancers. Okay. So you must put a panel. So based on the panel, okay, the panel has come out as SATB2 positive. So which means that it is probably a primary colon cancer with a Krukenberg. So how will you manage? Slightly out of our vogue, but yes, Dr. Ganesh, Dr. Maninder, anybody can take this.
Ma'am, if
How do you
the
manage
origin is colonic or if
Colon.
the origin is from rectum, we can
Yeah.
go for neoadjuvant treatment. Ma'am.
Okay. So and then is it neoadjuvant or palliative or what are you trying to do? What is the prognosis of a Krukenberg tumor? Generally, good or bad?
Poor prognosis.
Poor prognostic disease, generally, right? The prognosis, median survival is quite low. So, of late, there is a thought that if you do a cytoreduction, you're able to give a good cytoreduction along with chemotherapy, marginal increase
Yeah.
in the rates. Okay, so it is a possibility. So you could debulk if it is operable. Otherwise, you go and get a chemotherapy. So that is how you manage. Okay. Anything else, madam? I think come to the end of the. Yeah. Any other questions you'd like to ask, madam?
Thank you, Dr. Kavita, for the excellent moderation. We request Amita ma'am to kindly start loading up her screen. And when she does that, we'll hear from Dr. Kavita any suggestions from her to our two candidates today on how they can improve upon this discussion in exams and otherwise to prepare in future. And then we'll hear from Amita ma'am her comments on their performance.
Yeah, today's candidates, they did quite well. They were quite prepared because considering the rarity of the situation, no, you don't, in surgical oncology departments, generally, non-epithelial ovarian cancers are quite a rarity. So they did quite well, and I congratulate both of you on your efforts today. And I think we pretty much covered the entire thing today. So, Madam, your comments.
Yeah, so I think they performed well considering they were not aware of cases. And also, yeah, and rarity of the tumor. And I'm sure in real life also, you must have not seen many of these cases. Epithelial, which is more common, you see them day in and out. So you did reasonably well. And I think if you get these non-epithelial, it'll be a short case. So you have to prepare it accordingly. One suggestion is, I think if you waste a lot of time in just thinking or, not talking, because in the exam you have limited time. So they will allot you some 20 minutes for a short case. And if you spend a lot of time just thinking, I think, your time will go in and there will be hardly any fruitful discussion. So just be a little more attentive and prompt in answering. Otherwise, you both did well. Thank you very much, Dr. Ganesh and Dr. Nayak.
Thank you, ma'am.
Thank you.
We'll now hear from Dr. Amita Maheshwari, her expert talk on the contemporary and controversial issues in non-epithelial ovarian tumors. I request Dr. Kavita to kindly stay till the end because we'll have a short Q&A session after the expert talk. Over to you, ma'am.
Yeah, so slides visible?
Yes, yes.
Okay. Where is it? Okay, so my signals are not very good. So is it okay if I keep video?
Yes, madam, that's fine.
For some time. Okay, so thank you, IASO and Dr. Subramanieshwar Rao for the opportunity. In fact, most points we have partly discussed, and this presentation may be a little reiteration. So, what issues, contemporary and controversial issues I plan to discuss today are extent of surgery. So something about fertility sparing surgery, what's the role of lymphadenectomy and omentectomy in non-epithelial ovarian cancers? What's the role of resurgery after incomplete initial surgery? And what is the role of completion surgery after fertility is over, if fertility sparing surgery was done? I'll also touch upon the role of minimally invasive surgery, a little bit about the indications for adjuvant treatment and some of the syndromes. So just to put things in perspective, when we talk about Indian women, ovarian cancer actually is not a rare disease. If we look, it's the third most common cancer in Indian women after breast and cervical cancer. We see over 45,000 new cases per year. And large majority of these are actually originating from the surface epithelium and known as epithelial ovarian cancer. But 10% of these are non-epithelial. The most common non-epithelial sites are germ cell tumors, which originate from primordial germ cells, and sex cord stromal tumors. So as the name suggests, these tumors originate from sex cord or stroma of ovary. Apart from these, we do have other rare tumors, including lipid cell tumors, sarcomas, small cell carcinoma of hypercalcemic type, metastatic tumor, lymphoma, leukemia, melanoma, and many other miscellaneous tumors. So let's start with ovarian germ cell tumors, and what are the characteristic features which differentiate these tumors from epithelial ovarian tumor. So again, a variety of tumors are included in germ cell. They originate from germ cell. The important ones are immature teratoma, dysgerminoma, yolk sac tumor, embryonal carcinoma. Pure choriocarcinoma of ovary is rare, but non-gestational choriocarcinoma has very poor prognosis compared to gestational choriocarcinoma of ovary. And gestational choriocarcinoma could be either mets from choriocarcinoma of the uterus, or it could be ectopic pregnancy of ovary which has undergone malignant transformation or has developed choriocarcinoma in ectopic gestation. The prognosis of non-gestational choriocarcinoma is extremely poor. In fact, currently we have a young medical student and she has within 6 months of diagnosis of choriocarcinoma, she has failed 3 lines of systemic therapy. So their outcomes are extremely poor and it may be important to differentiate between gestational and non-gestational. So what are the key features of germ cell tumors in general? They present at young age. The median age is around 18 to 20. Large majority present with early stage disease, although they are highly malignant, but they are equally sensitive to platinum-based chemotherapy. And as a result, despite being very aggressive, their survivals are excellent, more than 90% in stage 1 disease. And since they are in young patient, fertility preservation is the most important point in their management. So when we look at tumors under 30 years, the most common, nearly 3/4 are germ cell. The other common tumors are sex cord stromal tumor and epithelial ovarian tumors. So in epithelial, generally in younger women, we will have either borderline ovarian tumors or low grade. So high grade just, although can rarely happen in young women, but they are not so common. The median age for epithelial ovarian cancer is in our setup is around 52 years. In the West, it's a decade later. How do germ cell tumors present? The most common presenting symptom is abdominal pain or lump. However, they may rarely present as acute abdomen, and you may, get them as surgical emergency, suspected ruptured ectopic. And this acute abdomen is due to either rupture, hemorrhage, necrosis, or torsion, and requires urgent surgical attention. A small number of patients, what we discussed, also may have isosexual precocity, and that's because of HCG production, so commonly seen with choriocarcinoma. And this will give rise to false positive pregnancy test. And occasionally these tumors may be detected during pregnancy. In fact, dysgerminoma is the most common ovarian tumor or cancer detected during pregnancy. The most common tumor is dermoid, but that's not a malignancy. So these tumors, gonad, although is the most common site of the occurrence, but they can occur anywhere along the line of migration of primordial germ cells. So one has to remember these rare sites, although they are less common in adults, but may find germ cell tumors at extragonadal sites as well. Now, how do we approach a suspected case of germ cell tumor? So tumor markers we already discussed. Young patient under 40, we will do alpha-fetoprotein, human chorionic gonadotropin, LDH, and CA-125. A chest radiograph. Radiological imaging, it could be a sonography, CT scan, or MRI. So the point is what you are trying to look at. If you want to know characterization of the mass, MRI is the best imaging modality. However, if you are looking for distant or extra ovarian spread, CT scan is a better modality, and it's more widely available and easy. Patients find it more comfortable. Now, karyotyping ideally should be done in all premenarchal girl, which may not be possible, but whenever we suspect gonadal dysgenesis, karyotyping should be done before planning the surgery. We already discussed about tumor profile. So dysgerminoma may secrete low level of SCG, and that is because of presence of in situ trophoblast. LDH can be elevated. Yolk sac tumors, alpha-fetoprotein is often elevated. Embryonal carcinoma, because that's from pluripotent cells, so it can secrete either HCG or AFP and LDH, all of it. Immature teratoma may be negative or may have AFP or LDH elevation, depending upon the component in the teratoma. Choriocarcinoma, HCG is the marker, and mixed germ cell tumor, depending upon the components, any of these markers may be elevated. About dysgerminoma, because it is slightly different from other germ cell tumors. So it's the most common in ovarian germ cell tumor, around 30 to 40% of all cases. Significant number of patients, I mean, compared to other germ cell tumors, can have bilateral involvement, 10 to 15%. For all other germ cell tumors, it's extremely low to have bilateral involvement. Lymph node metastasis is common in dysgerminoma, which is rare in other germ cell tumors, and these tumors are highly radiation sensitive. Having said that, radiation we rarely use because these tumors are highly sensitive to chemotherapy also, and which has less toxicity. Now, we discussed this point that dysgerminoma can occur in women with dysgenetic gonad, which could be either pure or mixed gonadal dysgenesis, or in women with androgen insensitivity syndrome or testicular feminization syndrome. So in most patients with gonadal dysgenesis, dysgerminoma will originate in gonadoblastoma, what Dr. Kavita just mentioned. Gonadoblastoma per se is a benign tumor. It's not a malignant tumor, and it's composed of germ cell and sex cord stromal cells. However, malignancy can develop in gonadoblastoma as high as 50%. Therefore, whenever gonadoblastoma is diagnosed, bilateral adenexectomy is recommended to prevent future development of dysgerminoma. Or if you are doing unilateral, if dysgerminoma is diagnosed on one side, other ovary, although may be looking normal, but in a dysgenetic gonad, it should be removed. Okay. However, uterus can be left. There is no need to do hysterectomy when we are removing adenexa, because uterus can be used for future embryo transfer, and as well as we can give exogenous hormones and a patient can experience menstruation. Yolk sac tumor, histologically Schiller dual body is the key characteristics, and Schiller dual positive tumors have better prognosis than the one with negative. And AFP is the marker. However, very rarely the yolk sac tumor may not secrete AFP. And the other name for yolk sac is endodermal sinus tumor. Immature teratoma, I think the thing important to remember is that grading, which we discussed, and it depends upon the amount of immature neuroepithelium, and it has both prognostic and therapeutic implications. So it's important that pathologists grade the immature teratoma. Coming to the treatment of malignant germ cell tumors. So the basic philosophy is whenever possible, do upfront surgery, and which is possible in more than 70% of patients because they present with early stage disease. And surgery is fertility sparing almost in majority of women, unless it's very late in life. And there, a more radical surgery can be done. But even if fertility is completed, and that you may see in Indian women, like, by 21, if patient has completed fertility, I think there is still role of doing a conservative surgery for ovarian hormonal function preservation. Adjuvant treatment is tailored based on subsequent histopathological type and stage of the disease. So some of the controversial issues, which, is the topic for this talk. What is the role of lymphadenectomy in germ cell tumors? It's controversial. If we look at lymph node metastasis in clinically early stage disease, in dysgerminoma, it can be in the to the tune of 10%, 7% in yolk sac tumor, and around 3% in immature teratoma. However, what is important to remember that lymphadenectomy has not shown to increase survival in clinically early stage disease, and there is increased risk of perioperative complications, what we just discussed. So this is a retrospective review of NCD data set, more than 2,700 women. Half of them underwent lymphadenectomy, half did not. What it showed that the overall risk of metastasis was 10%. However, there was no difference in overall survival between patients who had and who did not have lymph node removal. So excellent survival in both the groups. And after, in multivariate analysis, also lymphadenectomy was not associated with improved survival. And the conclusion from this study is that lymphadenectomy in apparently early stage disease is not associated with any survival benefit, and it's not recommended. This is another meta-analysis published last year, 14 studies, more than 10,000 patients. Again, nearly 50% had, and under 50% did not have lymphadenectomy. So results showed, although disease-free survival was better in patients who had lymphadenectomy, but there was no difference in overall survival. And also important to note that surgical time, blood loss, and complication rates, as expected, were higher in women who underwent lymphadenectomy. So this study and analysis also recommends that lymphadenectomy in clinically early stage germ cell tumors may be omitted. So what is the take here? May be omitted in patients who have clinically early stage adult germ cell tumors. IASO 2018 recommendation is lymphadenectomy is not considered a part of standard staging procedure in clinically early stage disease. However, if nodes are enlarged either on preoperative imaging or on intraoperative evaluation, they should be removed. And since dysgerminoma had the highest propensity, and these are the patients where observation is an option, so maybe lymphadenectomy has a role in dysgerminoma. But in all other tumors, if nodes are not enlarged, para-aortic lymphadenectomy is not recommended. The other question is role of omentectomy. Now, although we routinely remove omentum, the risk of metastasis in a grossly normal omentum is extremely low, less than 3%. So tumors like yolk sac or immature teratoma, high grade, where anyway adjuvant therapy is planned, it is reasonable not to remove a clinically normal looking omentum. Patients like dysgerminoma, where observation may be an option, one may decide to remove the omentum or may omit it. But, a patient, if omentum is disease, it has to definitely come out. But a routine omentectomy in tumors where chemo is anyway required, a normal omentum may not be removed, or a small, a detailed omentectomy at least is not required. So this is a retrospective multicentric study looking at the role of omentectomy. 268 patients, apparently early stage disease, 70% had omentectomy. However, there was no difference either in disease-free or overall survival in patients who had omentectomy versus who did not. And omentectomy anyway did not improve survival or affect fertility in patients with clinically apparent early stage ovarian germ cell tumor, regardless of the age. I think why it's important also, because if you are doing upfront surgery, you may address the omentum or assess it. But what is also important, that patients who have undergone incomplete surgery outside. So the question is whether we stage them, staging in the sense whether we do staging primarily for the purpose of omentectomy or lymphadenectomy or not. So it's a somewhat controversial topic. Restaging has shown to be of very limited benefit. So decision whether to do another surgery after incomplete surgery, and which is not really rare in our setup. Women would undergo surgery for presumed benign ovarian tumor, and only adenexectomy or some salpingo-oophorectomy type of thing is done. And then, they come to us. So what is important when we making decision to look at post-operative imaging, intraoperative findings, post-operative tumor markers, and histologic subtypes. So patients, if otherwise a candidate for adjuvant chemotherapy, and there is no disease seen on post-operative imaging, there is really no role of restaging of these patients. However, patients like dysgerminoma or immature teratoma, if negative imaging, negative tumor markers, surveillance is a good option. However, if some disease is seen on post-operative imaging or if markers are elevated, then resurgery is an option in these patients. I think the next point is fertility sparing in advanced cases. So early stage, definitely fertility sparing treatment. But how about advanced stages? So nearly 25 to 30% patients may have advanced stage at presentation. The question is, can fertility be preserved? The answer is yes. In large majority of patients, fertility preservation is possible because generally germ cell tumors involve unilateral ovary and they are highly chemosensitive. So fertility preservation is possible even in advanced stages. So the type of surgery we will do, we will remove the involved ovary, remove all metastatic disease. However, if the other adnexa is normal and uterus is normal, then we should preserve them even in advanced stages. So this is very different from other ovarian cancer, including epithelial ovarian cancer or sex cord stromal tumors. So in germ cell tumors, because they are highly chemosensitive, fertility preservation is possible even in advanced stages of disease. And this is a number of studies which have shown that whether you do more radical surgery or conservative surgery, it really does not affect survival. Radical in the sense whether we remove bilateral adnexa and or uterus versus you conserve, the outcome of patients even in advanced stages is not affected. Rarely we may see bilateral malignant germ cell tumors, especially dysgerminoma. So the question is what to do, and as the case we discussed today. So bilaterality is overall rare, but common, I mean, most common in dysgerminoma. So if it is possible, the way it was done in case we discussed, do self-ingophorectomy on more affected site and cystectomy on the less affected site. But if it is not possible to do, if normal ovarian parenchyma is not identified on either side, at least uterus should be preserved. So IASO guidelines also recommend that conservative surgery is preferred and every effort should be made to attempt to preserve the fertility. And in such cases, neoadjuvant chemotherapy can be considered prior to surgery. This is a very small study, MITO-9, a small number of patients. But what this study showed that it is possible to do conservative surgery in patients with bilateral adnexal involvement. However, one has to remember when disease is involving both ovaries, there is compromise in ovarian reserve after surgery and after chemotherapy. So one has to be vigilant of it, and at the earliest, if patient is not planning conception, go for oocyte cryopreservation. What about neoadjuvant chemotherapy and advanced stages? So it has been widely used and it is a reasonable option in patients who have extensive disease when debulking is not feasible. Patients who are in poor performance status, we do get such cases who will have performance status 3, hypoalbuminemic, very sick. Patients who have increased risk of surgical morbidity or as fertility sparing procedure. And, as I just mentioned, that fertility sparing surgery is possible even at interval debulking surgery in patients who have advanced stage disease. So the message is every effort should be made to conserve the uterus and ovary if normal. So this is a study from AIMS, Dr. Lalit Kumar and team. A study of 23 patients who were treated with neoadjuvant chemotherapy, and results are very exciting. So what it showed that 21 out of 23 were alive and disease-free at a median follow-up of 74 months. 18 out of 21 actually resumed menstruation, and 10 eligible patients delivered 13 full terms. So, conservative surgery after neoadjuvant chemotherapy in advanced cases has good obstetric outcome. What about germ cell tumor during pregnancy? As I said, this is the commonest ovarian malignancy seen during pregnancy. few points to remember that AFP and HCG are not useful markers because they are anyway elevated during pregnancy. However, they're beyond the range of pregnancy range, then of course they can be taken into consideration. If it's an early stage disease, surgical removal and continuation of pregnancy. Surgery is generally done in second trimester of pregnancy. However, if disease is advanced, surgery if possible, followed by chemotherapy. PEP, there is some, few studies suggesting that PEP can be used. However, some concerns with etoposide. So the alternative could be cisplatin and paclitaxel, but I think it's possible to continue pregnancy even in advanced stages of disease if patient is desirous of the child. Now come the role of minimally invasive surgery. Very limited role and very poor evidence in favor. Advantages we all know of MIS. However, what are the disadvantages? It include tumor rupture, spill, port site metastasis. Staging is often incomplete. Maybe highly selected cases with small tumor and expert like Dr. Subramanyeshwar Rao doing laparoscopic surgery may do, but I think what is important to follow oncological principle. And if that is not possible, it's best to go for open surgery. So I'll show some, one or two videos just to highlight what must not be done when we do laparoscopic surgery for adnexal mass. So this lady had fairly large mass, and this was a case of, I think, germ cell tumor. So what was done? It was impossible to access this mass laparoscopically. So first few punctures were made to decrease the size, to suck out the fluid. And because young lady fertility was a concern, so some sort of cystectomy was done. Remaining ovary was reconstructed, and then it was removed in an endobag. So the message is, however young the patient may be, however desirous of fertility she may be, but you should not do such procedures. The other thing which is a big no-no is morcellation and of ovarian masses. You may not get diagnosed, you may not, and most of the time we do not have diagnosis of malignancy prior to surgery in ovarian cancer. So, but this is again a big no. When you see such solid masses, you should never do minimally invasive surgery. Although cosmesis is good, but at the cost of patient's life. There's another, what we often see is port site metastasis. So this was a young girl who had laparoscopic surgery for dermoid. However, 9 weeks later, she presented with abdominal wall swelling, and this was a big growth. This was the site of port from where the dermoid was removed. The biopsy showed immature teratoma grade 3. So we did give her chemotherapy followed by surgery. It was a huge mass which was going from all through the abdominal wall and intraperitoneally. There was extensive disease inside the pelvis also. So we removed all of that, but at the end there was a big defect in the abdominal wall, and she eventually required a reconstruction. So cosmesis ended up, with a big ugly surgical intervention subsequently. So one has to be very carefully while doing MIS for ovarian masses. Okay, let's move to the indications for adjuvant chemotherapy in malignant ovarian germ cell tumor. And this is the conventional thing that in adult, all patients except surgically staged stage 1 dysgerminoma and stage 1A grade 1 immature teratoma, all other patients are candidate for adjuvant chemotherapy. And what we discussed, the standard first line protocol is a combination of bleomycin, etoposide, and cisplatin. 3 cycles for early stage disease, 4 cycles for advanced stages, and in 4th cycle we may omit bleomycin and we just give EP. And these patients often require a growth factor support because this is quite a toxic regimen. Now, second line, commonly used protocols include a combination of paclitaxel, IFOS, cisplatin. This is the one we quite often use, TIP or VIP, etoposide, IFOS, cisplatin, or VEIP, that's vinblastine, ifosfamide, and cisplatin. POM-AC has shown to be, but again, it's a very toxic protocol. And there are some reports on high-dose chemotherapy with stem cell support in highly selected patients who have failed previous many lines of chemotherapy. So the next is, after surgery plus minus chemotherapy, how is their menstrual and reproductive outcomes? So generally, during chemotherapy, a substantial number of patients will experience amenorrhea, but in large majority of them, menstruation resumes within 2 years actually of after chemotherapy. Rate of premature menopause is 3 to 7%, depends on patient's age and baseline ovarian reserve. Infertility rates are to the tune of 15 to 20%. So what about fertility counseling and reproductive assessment? Extremely important. We should evaluate ovarian reserve 6 months after the treatment. We generally do AMH level and can do antral follicular count. However, patient who have falling ovarian reserve, so the option is if patient doesn't plan to start, not plan to get married immediately, one can go for oocyte cryopreservation or ovarian tissue cryopreservation or embryo cryopreservation, because if they do not conceive, if they delay fertility for long, there is issue of premature ovarian failure. So reproductive outcomes are generally very good with conservative surgery. And there is slightly increased risk of infertility, but by and large, most patients are able to conceive. And if required, assisted reproductive technology is not a contraindication in patients who have been treated for germ cell tumor. And the other point here is at the completion of fertility, completion surgery is not recommended in germ cell tumors. A bit about syndromes associated with germ cells. So we discussed about growing teratoma syndrome and how do we diagnose it. So normalization of tumor markers. Despite that, there is increase in size and or number of peritoneal disease. And that can happen many years after the initial treatment. And when we do surgery, the component will be seen only a mature teratoma. They will not be immature component. So this is the criteria to diagnose growing teratoma syndrome. And it's extremely important to be aware of this because we have seen cases where disease recurrence or progressive disease has been labeled in cases of immature teratoma, which may lead to unnecessary chemotherapy. And this actually the treatment for this condition is not chemotherapy, but surgery. So one has to be aware of this situation. There's another syndrome which may be associated with ovarian teratoma, mostly mature cystic teratoma, is autoimmune hemolytic anemia. So patient would have progressive anemia, increased serum indirect bilirubin and positive Coombs test, which will not respond to steroid therapy. And the treatment is surgical removal of the mass. Again, one has to be aware, especially physician, patient who are not responding to a steroid therapy, or ultrasound of the abdomen is required to rule out ovarian pathology in patients who have refractory autoimmune hemolytic anemia. So this is our experience. This is slightly older data. We do have updated one also. So the median age in our series is 18 years. Nearly 1/5 actually were premenarchal. 80% had conservative surgery with preservation of ovary or uterus. And 10 patients who presented with advanced stage disease were treated with neoadjuvant chemotherapy. And 70% actually showed pathological complete response. And the overall survival in this series, including all stages, is more than 90%. I don't know if I have time to quickly talk about sex cord stromal tumors.
Yeah, madam, please go ahead.
Okay, right. So the second most important non-epithelial ovarian cancer is sex cord stromal tumor. And the key characteristics are, although they are rare, account for 5 to 8% of all ovarian malignancy. These are derived from sex cord and ovarian stroma or mesenchyma, what I showed initially. And they are, there are various combination of female cells, that is granulosa and theca cells, and male cells like Sertoli and leading cells. And because of, there are 4 or 5 cells involved, a variety of tumors can happen. And the key feature here is that these are the most common functional ovarian neoplasm. They are generally associated with hyperestrogenism. That's because of granulosa and theca cells, but rarely can be hyperandrogenic if there is predominance of Sertoli leading cell kind of cells. Generally, these are unilateral. Bilaterality is very rare. They can occur in wide range of age as opposed to germ cell tumors. So granulosa cell and theca cell, the median age of adult granulosa is around 50 to 55 years, while juvenile granulosa cell, Sertoli cell tumors, they occur in adolescent and young adults with mean age around 13 years. So this is what I said, the variety of tumors are, in this group of sex cord stromal tumor, depending upon the cells involved in the process. But the most important granulosa, both adult and juvenile, they constitute more than 70% of all sex cord stromal tumors. And this is the one we often see in our clinical practice. So how do they present? So generally juvenile present at younger age and adult will be at older age. The main manifestation is endocrine. So depending upon the age, if it's a pre-pubertal age, isosexual precocious puberty is a common presentation. If it's in during reproductive age, menstrual irregularities, it could be secondary amenorrhea or infertility. If it's in postmenopausal group, postmenopausal bleeding, and rarely they may produce androgen and virilization, which is not common. Generally, granulosa are, they produce estrogen, but rarely can be androgen predominance. Now, important to remember that because of excessive estrogen without progesterone, there is possibility of endometrial hyperplasia in up to 50% patients, and 5 to 10% have associated endometrial cancer. Ascites and pleural effusion may be associated in 10% of patients, and granulosa cell tumor, they may present with acute abdomen because of hemorrhage rupture and hemoperitoneum. So we do have, so we have seen a couple of cases presenting with the rupture. And majority are in stage 1, and the most key feature here is late recurrences, especially in adult granulosa cell tumors, and that's why long-term follow-up is extremely important. Now, fibroma is a benign tumor, but why it is important? Because it's often associated with Meeks syndrome, that is presence of ascites and pleural effusion. And, we do have cases where one thought of advanced ovarian malignancy, but and repeated TAP will come negative. So the point here is never give chemotherapy unless you have confirmation of malignancy. Just based on ascites and effusion and ovarian mass, don't never start on chemotherapy. And other syndrome which may be associated is Golling syndrome, which has ovarian fibroma with multiple basal cell carcinoma, dental cyst, and skeletal abnormalities. I have not seen this syndrome so far. The other rare but interesting tumor in this group is Sertoli leading cell tumors. They present in young adults. Well differentiated tumors, they are benign. They are very, window-line kind of pores, but poorly differentiated, they are highly malignant. And generally, these tumors have androgenic side effects ranging from defeminization to masculinization. And abdominal mass is present in substantial proportion of patients. So this is one of our patients who had Sertoli leading cell tumor and quite a big mass, unilateral. And after surgery, actually all her other symptoms disappeared except her voice, which did not change at least until her 5 years she followed with us, and her voice changes did not revert to normal. The other rare and very cute looking tumor is steroid cell tumor. So this could be either stromal lymphoma or leading cell tumor or NOS. So these are more or less benign tumor, generally have androgenic manifestations. However, some of them could be glucocorticoid secreting and can cause obesity, hypertension, and glucose intolerance. And rarely they are estrogen secreting. GnRH may suppress steroid production, but surgery is the mainstay of treatment for these tumors. Coming to how do we evaluate a suspected case of sex cord stromal tumor? So we did discuss about tumor markers. Inhibin B, especially, there are 2 A and B subunits. So inhibin 2 is more specific. It is often elevated in granulosa cell tumor. So a premenopausal women presenting with amenorrhea and infertility and elevated inhibin is highly suggestive of granulosa cell tumor. AMH is another marker which is highly specific. So a combination of inhibin B and AMH is often used as tumor marker for granulosa cell tumor. Depending upon clinical manifestation, you may like to do other hormones, including testosterone, DHEA, FSH, LH, and estrogen. We already mentioned this on previous many occasions that endometrial biopsy must always be done whenever a granulosa cell tumor is suspected, and imaging could be either MRI or CT scan, depending upon the clinical scenario. So surgery is the mainstay of treatment. In a woman who has completed family surgery is comprehensive staging, including cytology, biopsies, omentectomy, adenexectomy, and hysterectomy. However, in young patient, fertility preservation is a treatment. There are some controversial issues here also, like the role of lymphadenectomy, role of restaging, and minimally invasive surgery. So coming to the point of fertility sparing in granulosa cell tumors and other sex cord stromal tumors. So majority, they present with early stage disease and have unilateral tumor. Juvenile, in fact, have median age of presentation 13 years. So they present in young population, and they are definitely candidate for fertility sparing. However, unlike germ cell tumors, the fertility sparing treatment in sex cord stromal is recommended only up to stage 1C, 1A and 1C. 1B, if bilateral ovaries are involved, it's not advisable to conserve. However, anything more than stage 1, it's not advisable to do conservative surgery. Unilateral salpingo-oophorectomy with staging is the standard procedure. The opposite ovary just should be carefully inspected. However, biopsy or bisection of normal looking ovary is not recommended. The other point, a little controversial, is whether to do completion surgery after childbearing is complete or not. The point in favor is late recurrences are known. But the point against is most these recurrences are salvageable by surgery. So if patient understands and she is reliable to come for follow-up, we may delay completion surgery until the age of natural menopause. Now, what about lymphadenectomy? Like germ cell tumor, this issue is controversial here also. The risk of regional lymph node metastasis is rare in patients who have early stage disease, and routine lymphadenectomy has not shown to have any survival benefit. So generally, a systematic lymph node dissection, pelvic and para-aortic, is not recommended unless nodes are suspicious on imaging or on intraoperative examination. So that's the point. If nodes are suspicious or enlarged, you would remove them, but a systematic lymphadenectomy for apparently early stage disease is not recommended. And this is the evidence, many evidence, I'll show one. It's SEER database. So 1156 patients. Lymphadenectomy was done in nearly 50% patients. The risk of lymph node metastasis was very low, and there was no difference in survival. And there was, no difference based on stage, histology, or extent of lymphadenectomy. So the conclusion from this study is that there is no survival advantage of lymphadenectomy in early stage granulosa cell tumor and other sex-cord stromal tumors. Now, how about minimally invasive surgery? I think same remains true. Role is highly controversial because there is risk of tumor rupture, metastasis, dissemination of disease. So if at all, it should be done for very small tumor, and as long as you can follow oncological principle, that means remove the mass intact. But it can be used in cases if you decide to do restaging where main tumor has been removed and patient is only for completion surgery. Now, this is another controversial issue, whether to do completion surgery or not. So what are the points we should do? Because it gives information about the extent of disease and stage. And there would be some upstaging, especially in patients who have stage 1C disease to start with. However, points against a routine restaging is that there is no survival advantage. So we really don't know if post-operative imaging is normal. I think we may avoid, and if the first surgery has been at least salpingo-oophorectomy, a restaging may be avoided if post-operative imaging and tumor markers are normal. However, if upfront surgery was only cystectomy, and that does happen because many of these are young patients, then at least unilateral salpingo-oophorectomy must be done because the risk of recurrence after cystectomy alone is very high. So this is NCCN guidelines to overall management. If it's a stage 1 disease after comprehensive surgical staging, whether with or without fertility preservation, whichever way. Observation, if it's a low-risk patient, patients who have high-risk features like intraoperative rupture, a poorly differentiated tumor, or with heterologous element, the option given are either observation or platinum-based combination chemotherapy. Patients who are advanced stage at presentation after surgery, chemotherapy is recommended. Now, in younger patient, our policy is to give BEP, especially in juvenile granulosa cell tumor. However, if it's, adult, especially, more than 50, we prefer paclitaxel carboplatin. That's our preferred chemotherapy regimen. Radiation has very limited role. So we generally do not use this. Now, recurrences are quite common, up to a fifth-fourth of patients may experience, and late recurrences are known up to 30 years. The site could be anywhere, pelvis or peritoneal cavity or retroperitoneal node. The treatment is individualized. However, surgery is the preferred modality of treatment. Whenever possible, we do surgery. We have done up to 4-5 times of occasion surgery for recurrences if they are amenable to surgery. The role of hormone HIPEG is controversial and very limited evidence is there. Hormone therapy can be used. Some of these tumors are hormone receptor positive, and we do give them anti-estrogenic therapy, either aromatase inhibitors or progestin or GnRH. And targeted therapy, there are some reports showing that bevacizumab may cause stabilization of disease. So that's one option. And we have very limited experience with the use of BEV in recurrent granulosa cell tumor. Now, there are other uncommon non-epithelial ovarian cancer, which we do encounter. We have seen a couple of cases, and these are the ones. We have few cases of ovarian lymphoma, leukemia, of course, metastatic we do see. I think we have 3 cases of small cell carcinomas, hypercalcemic type, and we do have few cases of lipid cell tumor. I don't remember any patient of primary ovarian melanoma in past 20 years. These are some of our group. Our group has made some publications. So this is Dr. Santosh Menon, who is a gynec pathologist. He reviewed our experience with malignant mixed Mullerian tumors. Dr. Bharat looked at our outcome of teratomas who have developed malignancies. And we have few case reports of unusual presentation of germ cell tumor of ovary. A couple of other studies are being done. So to summarize, non-epithelial ovarian cancers are rare, and I think that's why they are very important, both for clinicians and pathologists, and often poses diagnostic challenge for pathologists. So acute diagnosis is extremely important, and therefore you need an expert pathologist. Many patients are young. Fertility preservation is important. So before embarking upon very aggressive and radical kind of surgery, just take an opinion from someone who is dealing with these cancer more often, and also involve an infertility expert early in the management of a young patient. Post-treatment reproductive assessment and fertility counseling are also important. Patients should be informed about the possibility of premature ovarian failure and early menopause, and options available, including oocyte cryopreservation, ovarian tissue cryopreservation, or embryo cryopreservation. The role of comprehensive surgery is less well defined than in epithelial ovarian cancer, and individualization is the key. I would say role of MIS is controversial, and it should be done only by an expert MIS surgeon. So this is my acknowledgement to our gynec oncology disease management group at Tata Memorial Hospital, especially to my colleagues, Dr. Pabashi and Dr. Vishujit, and my residents, Vijeta and Kanvini. So Dr. Pabashi, interestingly, currently working on granulosa cell tumor, and she's along with pathologist Neha Mittal looking at FOXL2 expression. Dr. Vishjit is looking at our data, our experience with ovarian cancer, which are metastatic and who have been primarily registered under us, and what was their outcome. So with this, I think I'll stop. Thank you very much for the opportunity and your attention.
Thank you, ma'am. It was really a comprehensive expert talk on the topic, and I'm sure the residents will use the opportunity on YouTube to go through these slides again and go through the references and refresh their memory on this. We now move on to the last segment, which is the Q&A, and I'll invite Dr. Kavita also to get her video on. Amita ma'am, even you can put your video on now that your screen share is off.
I think the video is on this. This components of surgical staging, madam has already said. So we only have to do, it's only a limited surging and staging in especially germ cell tumors. You do, or madam, it is such a comprehensive presentation. So we know that even in the setting of advanced disease, you try and do fertility preservation, do unilateral adnexectomy, contralateral ovary. If it's normal, you don't do anything with that ovary, only abnormal looking, you biopsy it. Even peritoneum, abnormal looking peritoneum, we do not generally do normal looking peritoneal biopsies. Abnormal looking peritoneum are to be biopsied. Omentectomy, again, abnormal looking omentum, or we generally do omentectomy. But then, madam, after madam's presentation today, probably I'll go and think over of doing an omentectomy and remove only enlarged nodes, especially in dysgerminomas. So that is the extent of surgical staging in germ cell tumors. So I think that answers the question.
Yeah. The second question is cytoreductive surgery advisable for ovarian sarcomas which have peritoneal metastasis? Amita ma'am.
So the answer is treatment should be individualized. If you think patient is in good performance status, her disease is such that you will be able to remove these metastatic tumors, yes, one should try, because surgery is the best modality. These are not very sensitive to either chemotherapy or radiation therapy. So if technically amenable, yes, surgery should be offered. We do give neoadjuvant chemotherapy if disease is too advanced, and if there is response, we do offer them surgery.
The next question is peritoneal delivery of chemotherapy an option for GCT ovary as standard of care, Dr. Kavita?
No, it is not. See, in germ cell tumors, by and large, even with just general, even with surveillance for a certain subgroup, and even in advanced tumors, just IV chemotherapy does give good survival in terms of more than 95%. So I don't think you have a role, even though these tumors do spread intraperitoneally. You can have peritoneal recurrences, but then intraperitoneal chemotherapy is not an option for germ cell tumors.
The last question is in germ cell tumors which have lung metastasis, will these patients ever be candidates for metastatectomy? Amita?
Individualization is the key. So if it is something which is localized, where either lobectomy or metastectomy can remove, I would say yes. And we also have to see chemosensitivity of this tumor. So if there are options of chemotherapy, I think yes, individual patient in good condition, disease which is resectable. More than germ cell tumor, actually we have experience with the gestational trophoblastic disease or GTN with lung metastasis and surgery metastectomy. But again, answer can't be yes or no type here. You have to individualize, and in a given case, answer may be yes.
That's all from the Q&A section for today. I thank both the examiners for being so patient and going through the topic in so much detail and taking their time with it. I invite our convener, Dr. T.S. Rao, to kindly deliver the vote of thanks for today's session.
I'm actually anxious that I may not be able to make it, because today has been a very tough day. The head and neck team needed my help for the upper thorax cervico-mediastinal tumor. And I'm sorry I could not welcome you, Amita and Kavita especially. And then I can see Raj Govind, the academician par excellence as far as IASO is concerned. And then our former president, Arnav Gupta, under whose leadership actually the whole program started. And the vice president, Sharad Desai, is also somebody who is logged in. Good to see them. They are very regular, every fortnight event that happens. And then I'm very grateful to Dr. P.K. Das, our president, and Dr. Chandramohan for their confidence on the IASO Academic Council and the team. As far as the session is concerned, it has been always up to expectations, because we didn't expect you all to perform anything less than this. I joined after the first 15-20 minutes, and the way the case capsules were made was something that I've seen. Kavita did a great job, and then she was very moderate in her moderation, very kind to students. And then Amita, of course, is a very seasoned campaigner. Any session that she is in, I could see 126 people logged in. I thought this is the highest ever. So that is something that is a tribute to the examiners. So the presence of Amita and Kavita was something that really added color to the whole evening. Thank you very much, Amita. You are all a family anyway. I don't want to thank you immensely, but it's a protocol to thank you. So we'll keep disturbing you because you are very good and very passionate about teaching. IASO thanks you from the bottom of its heart. And then the next session will be after 3 weeks, because the Tuesday is falling on August 15th. That will be informed later on. Thank you very much for now. The students also, thank you very much for volunteering. So all this happens by volunteering. So truly appreciate them because they are exposed to the scrutiny of the entire country. Apart from the examiners are generally very kind, but the entire country is watching them. So I think it's a good method of exposing them when they are young, so that they'll become great orators and speakers later on. For now, thank you very much. Both the examiners, specifically the IASO core team, the advisors, and all those who have logged in. See you again 3 weeks later. Thank you very much.
So thank you so much, Dr. Rao and Dr. Shukla and IASO for the opportunity. I really enjoyed being with you, Kavita, after a long time online.
Yes,
Thank
ma'am. Learned a lot so much from you. Thank
you.
you so much. Thank you, Subbu sir, for the opportunity.
you.
Thank you very much. Good
Bye.
night.